Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast. Ozcast. Simply head to ozcastnetwork.com for details.
Hi, it's Steve Davis here. This is part 2 of our 2-part investigation and discussion around BRCA and breast cancer. If you haven't heard episode 1, it's already out. It's episode number 30. Go back and listen to that first and then continue with our next guests. Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
Dr. Travis Brown, it has been quite a journey with this BRCA. How would you like to wrap up this 2-part episode?
Well, again, when you have a plan of an episode, sometimes it goes a bit different to what you're expecting. But look, I wanted to just finish off with explaining that what we were looking at this episode is one part of breast cancer. Breast cancer is a huge area. When we're looking at BRCA, or let's actually look at just familial breast cancer, the estimation of how much familial is in the whole diagnosis is about 10%. So 10% of diagnosis have a familial aspect of that. BRCA covers, of that 10%, about between 20 and 50% of it. So that other thing that Eryn was talking about is that mix of genes. Clearly, one gene, one disease is a very simplistic model. Many genes, that disease.
This is the polygenetics she was referencing.
That's right. So you'll get an interplay of genes as everything. This is just that little slice of that episode, and we have a whole bunch of other breast cancers to cover, which is why this will be one that we do of multiple parts. And come back and understand. Again, it is the most prevalent cancer for women, breast cancer. It's such a complex area. And as you saw in this episode, multiple medical specialties are involved, surgery is involved. So this is something that we will revisit a few times in future episodes. But I just wanted to put into context where that is. And it's just a very small segment, BRCA, but it is incredibly important. And to know what to do.
It takes a pathologist to break it down to one little slice, doesn't it?
It does.
Our discussion of BRCA continues in part 2 of our series now with our next guest, which is Associate Professor Nick Murray, who undertook his undergraduate degree at Cambridge University before completing clinical studies and later a Doctor of Philosophy research degree at Oxford. Professor Murray undertook medical oncology training in Auckland in New Zealand and Cambridge, UK, and was senior lecturer and honorary consultant in medical oncology at the University of Southampton in the UK. Over the past 10 years, he's specialised in the treatment of and research into breast and gynecological cancer. Professor Murray is active in breast cancer research. He's the study chair of the Australasian study Eliminate, looking at new ways to treat breast cancer medically before surgery, and is a former member of the Scientific Advisory Committee of the Australia and New Zealand Breast Cancer Trialists Group. Professor Murray is the Director of the Medical Oncology Unit with the Royal Adelaide Hospital Cancer Services and also works at St Andrew's Medical Centre with Adelaide Oncology and Haematology. Professor Murray is our guest here on This Medical Life podcast. Welcome, Professor Murray.
Thank you very much. Very nice to be here.
I'd just like to start with some background. Do you see many patients who have the BRCA gene or mutation?
In my practice, I'm probably seeing somewhere between 2 and 4 each year.
So when they come to see you, can you tell us what is the most common question or even misconceptions that patients with this gene mutation have?
I find that a very difficult question to answer, actually, because by the time they come to see me, they've generally, well, there are two two routes. One is they come from a BRCA family. They already know that they've been living with this cancer risk, and they've often got a very clear understanding of their situation. The other situation is when someone comes and they have risk factors that we might recognize as making it more likely that they would have a BRCA gene. The most common one that everyone thinks of is triple negative breast cancer, but sometimes it's a strong family history of breast cancer or ovarian cancer. And increasingly, we've recognized that pancreatic cancer in men and women and prostate cancer, obviously in men, are also associated with the BRCA gene. So we talk about one of the things we do when we meet them, as do the surgeons, is we take a family history. That's one of the very first things I ask about. And so those women where there is a sufficient level of risk, we discuss genetic testing. And I know you're going to be talking to a geneticist later in this podcast, Eryn. But very often, when we do have these situations where someone's at a higher risk of carrying that gene, in particular with the triple negative breast cancers, we'll initiate the process of genetic testing, and we surgeons and medical oncologists collaborate. We treat these women in particular with preoperative chemotherapy. Historically, that was because it gave us time to get the genetic testing and enable the woman to perhaps make a decision about whether she went ahead with conservative surgery or perhaps more extensive surgery, sometimes including bilateral mastectomies. Nowadays, there are much stronger reasons for offering preoperative chemotherapy, in particular for triple negative breast cancer, because we now know that we can use that treatment and the response to that treatment as an actual test for who should and shouldn't receive subsequent post-operative additional chemotherapy.
So just on the triple negative cancers that you do come across, is BRCA just almost done routinely on patients who have that morphology, that diagnosis?
It's not quite routine yet. If you're under 50, it's close to that. I think if you're under 40, I can't speak for the rest of the country, but certainly in South Australia, pretty much everyone gets gene testing, even when we're fairly sure we won't get a result. Over 50, it's a conversation. And increasingly, as the test has become cheaper, people are actually choosing to have it done. Even if it's at their expense.
So then with people who come to see you, have they normally already done the BRCA testing and know, or is this something that you can initiate as well?
Both is the answer. People don't come to a medical oncologist first with a new early breast cancer, except by accident, very rarely. They'll meet the surgeon, and the surgeon will frequently have had that conversation, but sometimes we work very closely together. If a surgeon sees someone who's going to come to a medical oncologist for neoadjuvant chemotherapy, the handoff happens very rapidly within a week or two. And so sometimes it's an ongoing dialogue that's initiated by one and continued by the other. We are very much working as a team.
You did mention the prophylaxis surgery. Is that something that a lot of patients go down? Is that a really, it's a significant operation for patients to consider. Is this an involved discussion you have with every patient, or is there some people that definitely want to do, definitely don't? How's that sort of work out?
Well, I say discuss it with your surgeon, and people are at different points in their lives and they make different choices. Younger women may want to have a pregnancy and perhaps breastfeed and delay that sort of prophylactic surgery until later, or they may not. Older women may very well choose that. But again, I don't think there's a one-size-fits-all in these situations at all. And different BRCA gene mutations do confer different levels of risk, although that's not a conversation we often get into.
Now, from an oncology perspective, is there any difference with a patient that you see being the age of BRCA positive, let's say less than 40, and between the ages of 40 and 60, and probably 60 plus? Is there any difference in the management that you approach with people in these age brackets with BRCA positive?
Right. First of all, the management of the cancer in the first instance is for the medical oncological management of the cancer is not driven by the BRCA positivity or otherwise. It's driven by the phenotype of the cancer. Now, I'll qualify that shortly. So a triple negative breast cancer, I've already mentioned, we will be offering that woman, recommending that woman have neoadjuvant chemotherapy. And actually, over the last few weeks, we've started adding immunotherapy to that. That's not something that's yet funded within the public health system in Australia, but the manufacturers have made that treatment available. One can only assume because they're expecting it will become available through the PBS shortly, and I do hope that that's the case because it has made a numerically very significant difference to both responses to the chemotherapy in the short term, and we've now seen data that suggests that 3 years later the number of breast cancer recurrences is reduced by an additional third over and above just conventional chemotherapy. But a woman under 40 may very well not have completed her family, may wish to preserve the option of future pregnancy. There are a couple of things to say about that. First of all, this is something that we discuss on day one. In fact, the surgeons discuss it on day one because fertility preservation treatments, egg harvesting, egg or embryo storing are routinely discussed with this group unless they say, I don't ever want to have children. I've had all the children that I want to have. So there's generally a short pause between initiation of treatment and diagnosis while those things very rapidly take place. And reproductive medicine specialists are extremely cooperative. They go out of their way to see these people within a few days and get things moving. When it comes to actually treating the women with chemotherapy, certainly the under 40 group, we offer treatment with a monthly implant of a hormone called, hormonal treatment called Goserelin, or Zoladex is what it's commonly referred to, the original, I think maybe still the only brand. And what that does is it turns off ovarian cycling, and there is some evidence that suggests if we do that during the course of delivering adjuvant chemotherapy, that reduces the risk that the woman will be permanently postmenopausal and unable to have children in the future.
So looking at the treatment, so patients who are BRCA positive, is there any specific treatments or prophylaxis these patients can have?
Right. So there is, and thank you for reminding me. So we do now have evidence that women who are BRCA carriers and at higher risk of later recurrence, if they are treated with a class of drug called a PARP inhibitor, a class that was specifically designed to treat BRCA cancers, then they will have fewer recurrences, substantially fewer recurrences than women who don't. This is not currently funded in Australia. It's something that if a woman's going to take it, she will have to pay for herself, and it's not cheap.
Just looking at the patients who have the gene, is there any recommended follow-up or surveillance for these patients?
Annual follow-up is recommended. Younger women will be offered follow-up with, and again, this is probably a conversation you've had with Melissa Bochner, who is much more across these things than I am, because she's the person who deals primarily with those things. So it's annual breast screening, and women in particular with denser breasts where it's more difficult to pick up cancers, they are offered annual MRI screening.
Mm. And just looking at the best approach that we have, BRCA has been known about for 3 decades, but but there's still patients and groups that we haven't identified. Is there any sort of hints that we could sort of give to find these patients or family members? Is there any tricks there?
Just when you say that, you remind me that 30 years ago, I went back to Cambridge to continue my training in oncology. And this was very much at the time when the genes had recently been identified. And Bruce Ponder was a professor of genetics who really had more to do with the discovery of those genes than anyone else. And he was talking about his experience, and he was absolutely horrified in his description of the first person for whom he made this diagnosis and told her she'd got the BRCA1 gene. She left her husband and he felt responsible for it. She decided to change her life. I don't know what that tells us, but I'm just reminded of it right now.
Oh, I think it's the impact that this diagnosis can have on patients and people.
It's the human aspect that when we have this discussion at the medical realm, it can be easy to forget. But obviously not for you. You're at the coalface. You're in the same room with these people, so that just makes it palpable.
We do talk to people about disadvantages of having the test, and we're generally talking about financial risks of not being able to get life insurance, for example. But I have to say, I never say to people, and you might leave your husband. I've never.
Yeah. Well, I mean, the other thing is to recognize the impact, and this is why some of that misconceptions, people often think they see the diagnosis, they see BRCA, and then they feel that they're going to have to get breast cancer, or they feel it's almost a death sentence. And this is one of those things that we're trying to demystify, this diagnosis, and understand that. And that's why talking with Graham and other people, that the age of diagnosis sometimes changes the management and how we treat these patients, but it's also recognizing that this is a risk factor, not a
certainty.
Yes,
yeah.
That's right.
There's a whole spectrum of what's called penetrance of this gene. You know, that one will meet some young women. I can think of someone I'm treating at the moment who her mother died at 30. She's 30. She's got it. You know, her decision making is driven very much by that experience. Other times, you know, there's a family history, but everybody's done well. And there is some evidence that if your genetic cancer, if other people have done well, then you're likely to do well as well. So, you know, there's this whole wide range of what the gene's going to do. Obviously, when one meets someone there's no family history, they've got this gene, again, there's a very wide range of reactions. But, you know, from I want you to well, not me, but to remove both breasts, take the ovaries, take the fallopian tubes and do it as soon as possible, to no, I want to wait. Everybody's different.
Professor Murray, do you have any final advice for doctors, GPs about BRCA, breast and ovarian cancer, or really anything in relation to this topic?
I don't know that I do, really. It remains a pretty specialised area. I think if you have someone who comes to you who says they've got it in the family, I would recommend referring to a clinical geneticist with an interest in specifically in cancer. If it's someone with a strong family history, again, but no known genetic disorders, then again, perhaps a referral might be appropriate, or a referral to a surgeon for assessment. I think one of the very important things to mention is that if a woman has a strong family history, even if she doesn't have any of the recognized genes, there may well be that familial risk, and she should be followed, screened for breast cancer in the same way as someone with a high risk gene.
Professor Nick Murray, thanks for being a guest on This Medical Life.
It's been a great pleasure. Thanks for inviting me.
Dr. Eryn is a dual-trained medical oncologist and clinical cancer geneticist. Eryn holds dual appointments at the Royal Adelaide Hospital as a clinical cancer geneticist with the Adult Genetic Service and a medical oncology consultant with the Youth Cancer Service, in addition to private cancer genetics clinics. She is a member of the Reference Committee for Cancer Genetics with the New South Wales Cancer Institute EVIQ Committee, as well as an executive committee member for the Human Genetic Society of Australasia Cancer Special Interest Group and the Clinical Oncology Society of Australia Familial Cancer Group. Eryn sits on the Advanced Training Committee for Clinical Genetics with the RACP and is the principal investigator for a number of clinical oncology and familial cancer genetics trials. Today, Eryn is our guest here on This Medical Life. Welcome, Eryn.
Thank you very much for having me.
I need to start with the really obvious question. What is the role of a clinical cancer geneticist?
That's a really good question, and I think it's perhaps not so obvious. And there is a bit of confusion between the role of a clinical cancer geneticist, a genetic pathologist, a genetic scientist, and a genetic researcher or academic. And so I guess the main part of my role as a clinical cancer geneticist really is as a clinician, and I'm a physician by training. And so what we do primarily is manage patients. And those are patients and families that potentially have a genetic predisposition to cancer. And we work with them throughout the process of clinical diagnosis, molecular genetic testing, results disclosure and adjustment to those results. And then we manage, of course, the family and the familial implications of those kinds of results. So while we work really closely with our colleagues in the lab and our research colleagues, our role is primarily clinical with the patients.
So at what point in the patient's journey, such as a patient's been diagnosed with BRCA, do they actually come to see someone like you?
Yeah, so usually from the very start. So genetic testing, there's quite a lot of limitations around genetic testing, and that's fundamentally because it's a complex test and also, unfortunately, an expensive test. And so most genetic testing can only actually be ordered by a clinical geneticist. So usually patients will be referred to us following the diagnosis of a cancer, or if they have a very strong family history of cancer, and we will see them and discuss the role of genetic testing in their family. And that being said, there is more and more of what we call mainstream testing happening, and that's where genetic testing is organized by a non-genetics healthcare professional. So in the cancer setting, generally an oncologist or a cancer surgeon would order the genetic test, and then the patient would be referred to us if a genetic variant of significance was found, what we used to call a mutation, but we try and move away from using that terminology a bit.
So then, in the case of BRCA, can you tell us what are just some of the common questions you get asked in your role?
Yeah, absolutely. I mean, we get asked lots of questions, and it does depend a little bit how much information patients come to us with. Lots of patients get on Google and come very informed and ask very tricky questions. But I think probably the two most common questions we get really are just, what does this genetic result mean for me as the patient? And what does it mean for my family? And sometimes people ask about their family first. That's actually very common in my experience. But really what we talk about with patients is the implications of a genetic result. So what it might mean for their treatment, which of course we talk about in discussion with their oncologist and their surgeon, and what it might mean for their future cancer risks and how we manage those risks, as well as, of course, what it means for their family members and the process of genetic testing and sharing that information within a family.
Looking at the role then of cascade testing in this, is this something that you discuss with the patient at the time and then go on to discuss with family members, or is this something that is further down after everything's been sorted with that patient?
Yeah. So cascade testing is also called predictive testing or pre-symptomatic testing. So that's testing blood relatives for a variant that's been identified in the family. And this is something that we try and talk about from the start, because genetic testing, different to other pathology tests that you may have, the result isn't just about the patient, it's about the whole family. And so we do try and open that discussion really early in our work with the patient. We offer predictive genetic testing to all blood relatives in a family where a variant is found. In the cancer situation, usually these are adult onset conditions. And so usually that testing is offered to patients over the age of 16 years. But there are a few exceptions to that, of course. And so that's a really key part of our role as a clinical genetic service, is actually managing that cascade testing and that risk notification process within the family.
So looking at this, because again, you're dealing with young adults coming through, is part of this almost counselling the result that comes through? Because just one of the things that Professor Murray mentioned was that the diagnosis to a patient was so dramatic, they changed pretty much their life. I think they left their partner. Is some of this almost coaxing them through or just helping them manage with this? Is that a significant part?
Yeah, absolutely. And although, I mean, you've specifically asked about the role of a clinical cancer geneticist, but I think it's important to realize I work as part of a team. And a big part of our team is our genetic counselors. And they're wonderfully trained allied health professionals that all have a master's degree in genetic counseling. And they work with us and the patients to really help manage a patient's journey, to help them adjust to these potentially life-changing results, and to help them cope with that, and also to help them provide strategies for talking to family members. So these results can absolutely change not only a patient's life, but a whole family's experience of a disease. And having that excellently trained group of allied health professionals work with us is really invaluable to helping manage patients through that difficult time.
Mm. Now, there's something that I have to ask, because when I was in the hospital working, I encountered some family dynamics that I probably wasn't prepared for as a junior doctor, that you just saw some difficult families and some patients. I remember seeing a patient in ICU who refused to see his brother, who had obviously a lifelong falling out with, and he was on his deathbed, and he's like, I don't want to see that patient. In these instances where families can be sometimes pulled apart for many other reasons, what happens with a patient says, I don't want this shared with family members, or I don't want them to know about this?
Mm, yeah, that can be a really challenging situation. And I think we all have worked with families where there are some very challenging dynamics. And I think probably we can all reflect in our own lives that families can have challenging moments. And so it is a big part of our job is family management. And I guess that's a bit different to a lot of other medical specialties where you're used to just dealing with the patient in front of you. But in genetics, we do really have to think of the whole family potentially as our patient. And I guess, again, I have to really support our genetic counselors here and the vital role that they play in helping manage these challenging family dynamics. But it really comes down, I guess, to establishing rapport with the patient and supporting them through that process of adjusting to a result. And you need to remember the timing of this can be horrendous. It could be a patient who's just been given a cancer diagnosis, which already disrupts their normal life. And the genetic information on top of that is just potentially more confronting and more overwhelming. And it can be really difficult to share. And it can raise a lot of complex emotions for people as well. And we can't underestimate the power of, that parental guilt, worrying that you've passed something down to your children. And we really need to unpack all of that with a patient and try and identify what the specific barriers to sharing the information are. And often with ongoing support and revisiting the issue over time, a lot of patients will come around to a point where they are happy to share that information with the family, even if it's only with one or two other family members. But then you kind of have an in to the rest of the family. And we do also in genetics offer an anonymous risk notification service. So we essentially write a dear relative letter that does not have any identifying details on it and does not identify the patient in whom the genetic fault has been found in the first place. But if the patient can provide contact details, addresses, or email addresses for their relatives, we can forward that from our department in an anonymous nature. And so help assist in that risk notification process, but keeping the original patient one step removed from it. But ultimately, patient confidentiality applies in genetic testing, just like it does in any other medical test. And we can't breach that patient's confidentiality. And the rules are a bit different in different states, but ultimately the legislation comes down to imminent danger or harm. And if you can't prove that, then you don't have a legal right to breach the patient confidentiality. And this is something that I don't believe has been tested in a court of law to date, but whether a genetic predisposition to cancer or a genetic risk of cancer, because that's what these people are inheriting, actually would qualify as imminent danger. And keeping in mind, of course, that even their close relatives, their first degree relatives like siblings and children, only have a 50% chance of having inherited the variant, because these are autosomal dominant conditions. And even if they've inherited the variant, these genes are not 100% penetrant, so not everyone will develop a cancer. And so I think to argue that that's imminent harm and you can breach confidentiality would be a really challenging legal argument to make. So ultimately, our responsibility is to the patient, and we do have to comply with patient confidentiality, but we try to support that as much as we can. And I guess just for my general practitioner colleagues out there that might be listening, often, I guess you're managing multiple members of a family. So you might have, parents and children that you're looking after. And you need to be very wary of that confidentiality as well, because you don't know what a parent has told a child or a child has told a parent. And so these results, just like any other medical test, are confidential.
I really get a sense, as the outsider from the medical world here, that we haven't necessarily gone deep legally into this scenario, because I could imagine in our family getting an anonymous letter, your curiosity is going to be piqued and conversations will happen. But the other thing that's entwirled with this, Eryn, this is you as a human necessarily than a doctor, is we hear this no person is an island as a philosophy. Your field brings that to a sharp focus. We are all absolutely linked. I feel this is a watch this space as we learn, thanks to your discipline, just how interconnected everything is.
Yeah, it can be very challenging, and you're right. It does kind of bring that family management and that interconnectedness to the forefront. It would be interesting to see if it was ever legally challenged. And I do agree that when patients receive a dear relative letter, it piques the curiosity. And often patients can kind of figure out for themselves where this genetic fault may have come from. But in families that are truly estranged, it is a way that you can share that information.
So, looking at this in this episode, we're talking about the role of BRCA and familial cancer. What about patients who are BRCA negative but still have a strong family history? What do we do with these patients?
Yeah. So I guess my first question in that situation would be, when was the patient tested? When did that BRCA1 or 2 negative result come through? Because testing technology and our knowledge of genetics is rapidly improving. So I guess any patient or family that was tested more than 10 years ago, we need to revisit, are they truly BRCA negative, or is there something there that just couldn't have been identified with the previous testing technology? Now, that being said, BRCA is really just the tip of the iceberg when it comes to breast cancer genetics. And it's they're the famous genes. They get all the press. They have a catchy name. But there are, 10, 12, maybe even more other genes that can predispose to familial breast and ovarian cancer. And so when we order a test now, a modern standard test, we don't ever actually just test BRCA1 and 2 in isolation. We order a panel-based test. We test, 10 or 12 breast cancer predisposition genes simultaneously. And there's a number of sort of different groups of those genes. There are other high-risk single gene variants. So for example, there's a gene called PALB2, which is partner and localizer of BRCA2. So from its name, you can kind of figure out what it does. And if you have a fault or a variant, pathogenic variant in that gene, you have a very similar risk of breast and ovarian cancer to if you had a germline BRCA2 variant, for example. There's also a group of genes called moderate risk genes. And these are breast cancer predisposition genes where the lifetime risk of developing a breast cancer isn't as high as a single high-risk gene like BRCA1 and 2, but is still significantly increased compared to the average woman in the general population. And these are genes like CHEK2 and ATM, and generally no one's heard of them. They're not famous. And they're genes that are a bit trickier to use clinically because that risk is more moderate. It's not at the extreme end. So it does make those risk management conversations a little bit more challenging, and you need to weigh up the pros and cons, particularly of invasive risk management, like risk-reducing surgery, more carefully. There's been a group of genes that I would call the syndromic breast cancer genes. And these are genes where carrying a pathogenic variant does significantly increase your risk of breast cancer, but that occurs as part of a complex syndrome with multiple other medical problems. So those are genes like neurofibromatosis type 1, or the PTEN gene, which causes what's now called PTEN harmatoma syndrome, but used to be called Cowden syndrome. So there are those other genes where the breast cancer risk is just part of a complex medical situation. And then the exciting thing that's kind of on the horizon, and I think will be available clinically within the next 5 years, is polygenic risk calculations. And this actually probably explains most of the breast cancer in the population. Because if we look at how many women get breast cancer, and it's sadly incredibly common, it's 1 in 8 women in Australia, only a very small percent of those women will have an underlying single high-risk gene like a BRCA gene. But the concept of polygenic risk, it looks at hundreds of genetic markers across the genome. And with breast cancer, there's more than 370 now identified genetic markers. And each one of those markers might increase or decrease your chance of breast cancer by a fraction of a percent. And what matters is the sum of those markers that you've inherited, the accumulation of all of those genetic risk factors. And those can be used to calculate what's called a polygenic risk score, which can be stratified as high risk, average risk, or low risk. And this is something that we're working with in clinical trials at the moment, and I think will be available hopefully very soon in the future, and will help us understand a much bigger proportion of the genetic and familial risk of breast cancer than individual high-risk genes like BRCA1 and BRCA2 have.
My goodness. This is a two-part episode, and I thought we'd gone as complex as we could, but what a dense payload to finish with. But with that glimmer of hope, this really sounds like a fascinating frontier where we're touching the edge of. And Eryn, in many ways, I was thinking before about how humans are linked to each other through our genetics, but you've underlined how important everyone, from the GP through to you and the others, all are interconnected in untangling this journey and giving visibility to patients. So I suppose on that note, for GPs listening into this, have you got any final thoughts, advice, ways of thinking about this, especially about BRCA, but the role of cancer genetics, clinical cancer genetics, anything to finish off with?
I feel like there are so many things I could say in this space. And I think my final kind of message would be to remember that cancer is common, and most cancer is not specifically due to an inherited genetic predisposition. And in that situation, you need to remember, of course, that families share environmental risk factors as much as they share genes. And so when you see a familial pattern, you can't just immediately assume that that has a genetic basis. And whenever we're seeing a family, regardless of a normal or a negative genetic testing result, you need to manage that family based on the family history, not just on the genetics. I think when in doubt, just reach out to your local genetic service. We do work as a team, and we've tried to, recently put together some referral guidelines and some triage guidelines. It's an ongoing project, but there's a ton of stuff available online, whether that's through our website in South Australia. Queensland has a great one if you're based further north. The EVQ Cancer Genetics website is excellent. And I guess my other piece of advice, something that, leaves me pulling out my hair in some situations, is that if you're looking after a patient with a cancer diagnosis and you think that genetic testing might be relevant at some stage, please store a DNA sample. Because if we don't have that DNA sample, then we're really limited in what we can do for the family. Because testing an unaffected family member is not particularly informative. We really need that DNA from a family member who's had a cancer diagnosis in order to offer informative genetic testing. And there's nothing more challenging than to have to sit down with a family and explain that unfortunately there's no sample available from their deceased relative. And so there's nothing we can offer them in terms of genetic testing.
Wow. I'm going to sneak one last question at a language level in. You said at the beginning, mutation is a term you don't like to use these days. Is it just the pejorative sense of the word mutation, or is it just a blunt word that misses nuance?
And probably both. And I mean, some people like the word mutation. It takes them to, a happy X-Men kind of place. So we try and be guided a bit as well by the language the patient is using. And if that's a word that they're comfortable with, then we can use it. But I think the classification of genetic variants or changes in the genetic code has gotten quite complex. And we now have 5 classes of different types of genetic variants. And I think using the word mutation misses some of that subtlety. So we do try and refer to them as, pathogenic variants or likely pathogenic variants, although it is more of a mouthful. And realistically, when I'm talking to patients, I usually talk about a gene fault or a gene error as kind of a nicer terminology than referring to your patients as mutants.
Well, exactly. And Dr. Travis Brown, as a coder, would like that because there's often error in your code. Dr. Eryn, thank you so much for joining This Medical Life.
Thank you for having me.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a PathNotes Proprietary Limited production.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.